and I'm sure it's very traumatic for people to lose their legs due to critical limb ischemia. I have nothing to disclose for this, and the VA system has a dedicated prevention amputation care team essentially to prevent the high prevalence of veterans being amputated for critical limb ischemia. All these patients are referred to our multidisciplinary evaluation, and variables like perfusion, functional status, patient status, and the wound are evaluated to eventually stage the lower extremity tissue loss. And they are assigned on our intention to treat in our institution to revascularization group, a conservative group, a palliative limb care group, or a primary amputation group. And we have over the last 6 years 506 limbs with tissue loss, all of them with PAD, so these are critical limb ischemic patients. And 43% of them were assigned to revascularization, 31% were staged conservative group, primary amputation were staged in 8.8% of the time, and palliative limb care was staged in 14% of the time. Now, to be included in the revascularization group, you have to have documented wound history that is not healing, PAD by pulse exam, non-invasive evaluation, and TCPO2s being lower than 30 millimeters of mercury, and be an anatomic candidate for revascularization. To be a candidate for a conservative group, it's kind of the same thing, but the TCPO2s, the non-invasive evaluation by oxygen delivery, it's more than 30 millimeters of mercury. This is done by a previous study in our institution. And these patients have to be followed weekly and biweekly for monitoring of the wound trajectory, and is expected to heal within 6 months. For palliative limb care, these are patients, again, with documented critical limb ischemia who do not have rest pain, who do not have pedal abscess, or sepsis, and do not need a very intensive local wound care, and they are considered unfit for revascularization. And the bottom line is these patients are expected to die before they're actually healed their wounds, and that's why they're deemed palliative limb care. And the overall demographics, Caucasians make the lead 73% of the time. The mean age is 68 years or so, and the follow-up ranges from 1 month to 48 months. Prior cardiovascular events in this patient, very prevalent, 54% has coronary events, and 26% had cerebrovascular events. Diabetes, 77%, hypertension and hyperlipidemia, high 80%, chronic kidney disease in 40% of the patients, vascular risk factors. Tissue loss representation, 60% of the time are going to be non-healing ulcers, 30% of the time is going to be gangrene, and about 37% of these patients will have a stagnant prior place surgical stagnant wound. The overall survival is actually bad for the overall group. You see there the 4-year mark, 36% of the cohort is alive. The rest of the patients by that time are dead. You see this table, tissue loss presenting by limb staging. So if the patient was staged to have revascularization, the ulcer prevalence is 114, the conservative treatment is 142, primary amputation 17, and palliative limb care 43. So what this table shows is there's not really a bias in terms of the lesion presentation and the type of intention to treat group that you are stage 2. In this table, you'll see the wound healing rates and the recurrent if the wound healed by group. And you'll see that when the patients are staged revascularization, 63% of the patients heal. And this is kind of an important point because you think that if you had going to be revascularization, the patients are going to heal. And as you know, that's not the case. Despite successful revascularization, only about one third of the patients will still have no wound healing. Now, all of those who heal their wounds, you have an 11%, we observe an 11% recurrence rate over time. And this stresses out the fact that these patients have to have a continuous follow-up pretty much for lifetime. And in this moment, 12% of people who have received a revascularization have an active ongoing wound at this time. And some of these patients may die before they actually have the wound healed. When you have a conservative allocated group, again, you observe a 63% wound healing rate, a 28% recurrence rate of those who healed, and a 19% active wound status. And those patients who have palliative limb care, remember these patients we believe they're not going to heal, they have negative predictors on tissue perfusion, but they still surprise us every so often. We have observed a 7% actual wound healing rate in the palliative limb patients. This is limb salvage by staging. As you all know, you don't necessarily need to amputate somebody who has a minor tissue loss. So the overall limb salvage rate is 90%. Again, for you are a revascularization patient, you have an 84% limb salvage rate. When you have conservative treatment allocated patients, 95%, and palliative limb care, 87%. And again, this is a reflection of bias of selection and bias. Limb care patients tend to die with intact legs before they progress to pedal sepsis or overwhelming tissue loss. Survival by limb staging, there's a very significant difference. As previously stated, people with revascularization and conservative treatment are overall in good shape. At 4 years, you have 36% and 40%, which is kind of what we expect for critical limb ischemic patients. And you see the palliative limb care patients, you have nobody alive at 4-year mark, and you have a glancing 40% death within the first year. So what this is telling you that we are selecting properly, and the palliative limb patients are actually very high risk for mortality. This is a table that shows you on this variance and trying to explain the high mortality rate on critical limb ischemia, whether they are or not adherent to the American Heart Association guidelines of prevention of cardiovascular events in critical limb ischemia. And you'll see that 25% of patients were not at goal taking antithrombotic therapy, 28% were not at goal for hypertension markers, 20% were not receiving beta blockade with prior cardiovascular events. Hemoglobin A1C not at target was 58%. And as you all know, hemoglobin A1C has not yet been associated with a decrease in amputation rate, but it's definitely a decrease in microvascular things and renal dysfunction and some revascularization for coronary as well. So all this non-adherent may explain why patients have this significant mortality over the next 4 years. Regarding the revascularization allocated group, we performed 213 revascularizations for critical limb ischemia. Over half of them are endovascular, 32% were venous bypasses, 10% utilization of graft bypass only, and a hybrid between endovascular and venous bypass in about 8% of the time. And this is a natural history of the revascularization group. We have 124 patients, limbs, that heal their wounds, and 24 of these patients have recurred. 7 of these recurrent patients have received reintervention. 1 have had a secondary amputation, and 16 patients had a patent bypass graft but a difficult wound, so they maintained a conservative approach and they do wound care. There's 26 patients actively in follow-up at this point, and then we have 63 patients who failed revascularization. And the definition of failure for our institution is a patient who has not healed beyond 12 months or a patient with hemodynamic failure, meaning the revascularization we did has failed. Half of these patients who fail revascularization will end up with a secondary amputation. So this is kind of an important point. A palliative group were allocated in 1, and about 30 patients died while patent revascularization without wound healing. And we consider those failed because the overall endpoint of anything we do in limb preservation is to heal the wound. When your patients are allocated for conservative treatment, you'll see there the statistics are very much the same. You have a failure rate or so. So in conclusions, Mr. Chairman, our PAC program allows to comprehensive evaluation. Only 8% require primary amputation as initial treatment. The overall limb salvage is 90%. Despite increased awareness, the adherence to AHA guidelines is low. The 43% of limbs that we see require primary revascularization. And despite successful revascularization, 1/3 of the patients will not heal their wounds within 12 months regarding lifelong follow-up. Selected patients perceive a high risk for revascularization with a low life expectancy are safely treated by palliative surgery, and those patients do not die from limb-related complications. Thank you very much.